Hello, everybody. Good morning, good afternoon, or good evening. Thanks for attending this MASC webinar, the Multinational Association of Supportive Care in Cancer. And the topic tonight will be nausea and vomiting during cancer course Back to the Future. Thanks to Helsinn for this unrestricted educational grant from them to do that webinar. The agenda today, if I can have the next slide. Thank you. The agenda today, as you can see, will cover three very important topics. The first one will be a new approach to improve prophylaxis, like Dr. Laurent Zelek from France. We then will have Christina Ruhlmann from Denmark, nausea, how to assess, how to manage and related unmet needs, and then sparing steroids, how to move on by Dr. Matti Aapro. Christina Ruhlmann, thanks very much for being with us. You're from Denmark, from the Department of Oncology, Odense University Hospital. You're associate professor in oncology, involved in supportive care in numerous fields and societies as ESMO and MASC. You are the vice chair of the Antimatter study group of MASC, and it's a very great pleasure to work with you on the MASC Society. Laurent Zelek, you're a professor in oncology at Helsinn Hospital, close to Paris in France. You have always care your patients with a double focus on quantity and quality of life, and you're involved in the AFSOS, the French-speaking Association for Supportive Care in Cancer since its creation. Your interest in the topic tonight in nausea and vomiting will summarize in the coming publication in probably a couple of months. And Matti Aapro, thanks very much for being with us. You're a key worldwide leader in supportive care from Switzerland, Clinique Genolier. So you're an oncologist interested in breast cancer and the care to the elderly. You always tried to ease contacts between nations, between health professionals and all the disciplines over the world in order to improve quality of life to the patients. It's a very great honor to receive your educational talk on sparing steroids and CINV. So, the next please. What about MASC? MASC is a multinational association with an interdisciplinary approach. It was founded in 1990, as you can see on that slide, with more than 70 countries represented by members. So it's a very worldwide member group. As you can see, it's open to many professionals, physicians, surgeons, but also dietitians, nurses, dentists, pharmacists. So please be member of MASC. You will see that it will be very interesting for you, and you will have the opportunity to collaborate to build a very great network with with experts from the world. You will have the opportunity to have free online access to the official MASC journal, Supportive Care in Cancer, and also the monthly publication about the news on supportive care. You will have discounted meeting registration fees, and also the access to scholarships and awards. So it's very interesting for everybody to be member of MASC, and please join the www.masc.org in order to pay your fees and become a member of this wonderful association. As you can see on that slide, we have many study groups very interesting, and the first one is our interest tonight with the antiemetics. You also can be involved in psychosocial hemostasis, oral care, and nutrition and cachexia or survivorship, of course. So the annual fees, as you can see on the slide, is with the online journal, 75 euros for 1 year, and $140 for 2 years. For everyone who wants to become a member. As you can see, we have different proposals for people coming from low-income countries. It's really important to share with you if you're coming from such countries, because you have your expertise, and we want to share with you. We also have special price for trainees, etc. So the MASC annual meeting will be at Toronto this year in 1 month, June 23 to 25. So you can register today on the same link, www.masc.org/2022 registration. The meeting terms, as you can see on the side, are around COVID-19, of course, but also disparities in supportive care with solutions that will be given during the meeting. Big data is, of course, the current very important topic, and the predictive analytics in supportive care. We will also share discussion on patient empowerment and the self-management, and huge topic, burnout in oncology for both healthcare professionals and caregivers. So please register today. So during this webinar tonight, please use the Q&A function to enter your question. We will discuss the questions at the end of the 3 talks delivered by the 3 very great speakers, and you can use the chat to interact with your fellow viewers. A recording of this webinar will be available only for members via the MASC monthly newsletters. It's because you have to become a member tonight, become a member of MASC. So, thank you for the next one. I will give the talk now to Laurent Zelek. Laurent, you take the talk for the long delayed CINV after 5 days, a new approach to improve prophylaxis. Yes. Thanks again for being with us.
Thank you, Florian. Can you see me? I will try to share my my presentation.
But we are on the slide number 8. The provision. Yes, good.
Good. That's fine.
Next one.
Next one. Thank you, Florian. Okay. So thank you for this invitation. This is a rather difficult topic, but I have a lot of difficulties today because it was not possible to load the background. So I'm sharing this wonderful view of my office. CINV, first I will show you my conflicts of interest, because among the conflicts of interest, I've been the coordinator of a study with Vifor on nitupetant and palbociclib. So the long delayed CINV, it's something that has been very neglected during many years. As it has been written a few years ago by Matti, it's delayed CINV is still an unmet clinical need. Perhaps because we made such a huge progress 30 years ago with acute CINV, but the attention of clinicians didn't focus on this topic. And in some patients, in some cases, you have up to 50% of patients who are faced with delayed CINV, and especially nausea. The definition is rather straightforward. The CINV are defined by the onset later than 24 hours after the chemotherapy. There is a physiopathological reason which is very clear. The mediators involved, the physiopathology of this nausea and vomiting are not the same, and in CINV, after 24 hours, the neurokinin 1 is involved. However, it has never been stated that CINV should stop after 120 hours. This limit has been given in studies for practical reasons, but if you don't search something, you won't find it, and you will think that it doesn't exist. In fact, it exists. So just ask the patients and you will see that a lot of them are faced with protracted nausea up to 1 week after chemotherapy. And I will focus during this short presentation on 2 recent studies who show that even with up-to-date CINV prophylaxis, there is still a number of patients, I'm thinking about 20%, that have nausea and sometimes vomiting more than 5 days after the beginning of chemotherapy. And we now have some evidence that CINV can persist until 168 hours after chemotherapy. So the story began a few years ago with this Japanese study, was a dose-finding phase 2 study using IV NK1 antagonists, the fosnetupintat. So it's not exactly the same kind of drug that we use in Europe because we prefer oral prophylaxis. But you can see that in the study, you already had data up to 168 hours after the beginning of chemotherapy, which was something rather uncommon. And it led to the phase 3 study. The phase 3 study, so I'm sorry, I had some technical problems. Now, the phase 3 study is the console trial. You have in this study a huge number of patients with 795 patients. It's a non-inferiority head-to-head phase 3 comparing fosnetupintat versus fosaprepitant. And again, today it's not the most interesting point with this study. The primary endpoint was the overall CR rate up to 120 hours. And this study demonstrated the non-inferiority of fosnetupintat. Today, the most interesting things, to my opinion, is the secondary endpoints. We included a lot of endpoints such as complete protection, no significant nausea, and essentially the duration of the follow-up up to 168 hours. Now let's have a look at this. Here you can see this this period after 120 hours. You can see there is about between 20 or 50% of patients who are still experiencing nausea and vomiting very long after the beginning of chemotherapy. And there is a question regarding fosnetupintat because this drug has a longer half-life and perhaps might be a little bit interesting regarding the control of this protracted nausea. However, it's very difficult to draw the definitive conclusions because it's a non-inferiority study. Now you have another presentations of this data. You have the incidence of nausea and emetic events, and you can see that during this period, after 5 days post-chemotherapy, there is still a sizable incidence of nausea and, in some cases, vomiting, with again the question of a small difference between netupintat and aprepitant. Now let's move to the second trial. This trial has been done in France, and again it was a non-inferiority trial. The purpose was to compare the classical prophylaxis with aprepitant and ondansetron dexamethasone to the NEPA combination. So This is the combination of netopitant and palonosetron. And which was a little bit original is that it was the first comparison in moderately emetogenic chemotherapy. With NEPA, we had a lot of data in highly emetogenic chemotherapy, and such a study was still lacking, including AC, anthracycline and cyclophosphamide, and non-AC moderately emetogenic chemotherapy. It was something very practical, and we collected the data during the first cycle of chemotherapy. So really a real-life study. And the primary efficacy endpoint, as usual, was the complete response during the overall phase, 0 to 120 hours. So here are the results. And the main conclusion is that we showed the non-inferiority of NEPA versus aprepitant. So it was a very interesting result. And a remark, again, it's difficult in non-inferiority studies, but there is a really meaningful difference if you look at the control, the complete response during the overall phase. You will see that the difference is really important. It's much higher than the non-inferiority margin, which was set at minus 10%. So although it's a non-inferiority trial, this difference was really, really impressive. Now, what I will show you is the secondary analysis. We had data that are submitted for publication regarding the subgroup of the patients with moderately emetogenic chemotherapy, excluding the anthracycline cyclophosphamide regimen, so mainly breast cancer patients. And it's in this group of patients, we had a lot of patients with carboplatin, oxaliplatin, irinotecan. And furthermore, we had data until 144 hours, so an extended duration of follow-up. You see that we have again the same kind of difference. This is the global population of moderately emetogenic chemotherapy. You see again that this difference is really meaningful. And here in the delayed phase, you have a difference which is comparable to what has been observed in the Japanese console trial. And these are the data concerning the patients with risk factors, usual risk factors, age less than 50, female patients, and for example, some patients with anxiety. And you see again that there is a difference between netopitant palonosetron and the standard treatment with aprepitant, and it includes the overall phase up to 144 hours. So in conclusion, this is an emerging topic, and we can consider that about up to 20% of patients are still faced with long delayed CINV, even with modern prophylaxis. And regarding this point, which deserves further research, perhaps the long-lasting agent netopitant, which has a very long half-life, might be interesting to optimize the control of long-delayed CINV. Thank you for your attention, and I will so leave for the other presentation. Thank you.
It's time to introduce Christina Ruhlmann. Thanks, Christina, for sharing your screen.
Thank you very much. Thank you, Laurent, and thank you, Florian. So I'm pleased to be here and to give you a talk about nausea. So thank you very much. So these are my conflicts of interest. So just a quick overview of what I'm going to take you through these next 15 minutes. So we'll have some general considerations about nausea, how to assess nausea and how to manage, and then we'll round off with a conclusion. So one thing that is very important to take into consideration is the definition of nausea. So nausea is something that the patient tells us about. It's not something that we can measure like vomiting, the quantity. So this is a feeling, it's like a queasy sensation, it's an unpleasant sensation, feeling of sickness, diffuse sensation of unease and discomfort, and very often perceived as an urge to vomit. So surely this is where we really need the patient to give us a clear look into their symptoms by telling us because we can't measure it. So there are certain risk factors for patients having nausea, and not to go into details with these, but we have to be aware that there are both patient and disease-related risk factors. We have some treatment-related risk factors according to the immunogenicity of the chemotherapy, targeted therapies, immune checkpoint inhibitors, and radiotherapy. And we do also have some external factors that we need to be aware of that we can actually modify in order to either alleviate or aggravate the symptoms. So nausea is something that a patient can experience throughout the whole cancer trajectory. So the risk and the causes of nausea varies. So in the curative setting, it's more the nausea from the active treatment like chemotherapy-induced nausea and vomiting. In the rehabilitation and survivorship, it's more linked to the late effects of the disease or of the treatment. And during palliative treatment, it can both be the antineoplastic treatment, it can be caused by symptoms from the disease itself. And in the end-of-life setting, it's the disease itself, complications to the disease that makes the patient experiencing nausea. So what about patients' own perceptions of these side effects during chemotherapy? So these are 3 different studies, all where the patients were asked to rate and then rank according to severity, how severe the symptoms were. So there were both physical symptoms and psychosocial symptoms. And as you can see, nausea is one of the most distressing symptoms to chemotherapy. And it continues to be that, even though we have some very effective antiemetics coming to nearly the most of the world during the early 90s, where you can see vomiting went to the 5th most distressing, whereas nausea now is ranked number 1. So nausea is still one of the symptoms that we really have trouble controlling, whereas vomiting we are actually doing quite well. We have a lot of neurotransmitters which we can address in order to block the symptoms as nausea and vomiting. And one of those best described is the function of serotonin, with a release due to chemotherapy from the small intestine to the bloodstream or through the synapses to the vagal afferent nerves, projecting to the medulla oblongata, the area postrema, which in turn projects to the what we used to call vomiting center, now more or less better described as a central pattern generator. And from here we have the physiological symptoms of retching and expulsion of stomach content. So we have these 3 dominant neurotransmitters: dopamine, serotonin, and substance P, and we have receptors to block. We have to bear in mind that we have many other neurotransmitters, but for simplicity, we'll only address these 3 for this talk. And then we have some receptor antagonists that we can, with those we can block the receptor, and those and hence we can block the symptoms. So now what we want to assess nausea. So how do we do that? Well, as Laurent was clarifying, we can divide in chemotherapy the periods where patients experience the symptoms as an acute phase, the first 24 hours, and a delayed phase up to the next 120 hours, or maybe it should be expanded to up to 168 or whatever for the delayed phase, because truly many patients are not just experiencing delayed phase 2 days 5 as demonstrated. This is the way we do it both in clinical trials, but also for the purpose of addressing nausea and vomiting in the daily clinic, when to use which kind of antiemetics. So if we ask patients to give their opinion about how severe nausea is, then we can use the Pro-CTCAE, and for this patients can tick off how often they had nausea during the last 7 days, and how severe it was. And if we ask the clinician to do the same, we'll have to ask the patient about certain surrogate markers for having nausea, because it is a sensation. So we cannot ask about loss of appetite, decreased oral intake, the need for tube feeding and hospitalization, and hence we can grade nausea according to the CTCAE. We can also use the MAT. Many of you might be aware of it. And this is used for the purpose of modifying the next antiemetic regimen for patients undergoing chemotherapy. So patients are asked about the 24 hours after chemotherapy, the last cycle, and the delayed phase, and both for vomiting and nausea. And then we can make a suggestion if we should, if there's anything to do better for the next cycle. We have other assessment tools also, and those are often used in clinical trials, sometimes also in daily clinic. We have the EORCT, QLQ-C30, and the C15 PAL, and patients are asked, and these are also patient-reported outcomes. Have you felt nausea? And on a four-legged scale, they will have to rate between 1 and 4. And we have the Edmonton Symptom Assessment System, very often used in the palliative care setting. We have other tools also used in clinical trials, the Functional Living Index EMISIS scoring system for items for nausea, items for vomiting, and we have the Index Nausea, Vomiting, and Retching Scale, and you might be able to provide other tools too. So this is how we assess nausea. So in clinical trials, when we, if we have a look at how we actually know how good nausea is controlled, it's quite sad to see, or I don't know, it's sad because we had to start somewhere, but it has very, it has been, the primary part has been how to control vomiting, because that's a thing to measure. So it's much more easy in a clinical control trial to measure the efficacy of a treatment if you can measure it. So these are some of the pivotal trials in antiemetic where we have the addition of an NK1 receptor antagonist for the 5 studies on your left-hand side, an addition of an NK1 receptor antagonist to dexamethasone and serotonin antagonist. As you can see, there's a clear benefit in the addition of an NK1 receptor antagonist. And this is both true for the HEC and MEC, so the high emetogenic and the moderate emetogenic chemotherapy. And if you take a look at the right-hand side, then we have the study which Laurent took us through. So the head-to-head comparison between fosmetopetand and fosaprepitant, where we see a non-inferiority of for the 2 drugs with a small numeric difference. So this is a complete response overall. So this is no vomiting and no use for rescue antiemetics. But what does that bring us of news about how is nausea managed actually? So we could say that the no use of rescue antiemetics could be a surrogate marker for nausea. but it would be much better to have set nausea as the primary endpoint. It is fortunately used as secondary endpoints in all these pivotal trials, but so you know the strength of so the significance of when we have the p-values for the secondary endpoints. It's more or less just hypothesis generating, so we have to bear that in mind. But it's very interesting to see that the control of nausea is much less efficient as opposed to the control of vomiting. So as you see for all studies, so in general, more than 50% of patients will experience nausea during the cancer treatment or the chemotherapy, whether they are treated with an NK1 receptor antagonist or alone with dexamethasone and a serotonin receptor antagonist. So there's something that we need to do better for controlling nausea. So it's very welcome that this study showed us, well, a nice study including 380 patients, with patients receiving high metagenic chemotherapy, cisplatin more than 70 milligrams per meter square, or AC chemotherapy. And they had the normal guidelines consistent chemotherapeutic regimens, triplet antiemetics. And then in the one arm, there was an addition of olanzapine 10 milligram and placebo in the other arm. So what they found was that there was the very good thing here is that the primary endpoint is actually no nausea overall. So very ambitious, very nice. So for no nausea overall, we saw a benefit in the arm where they had an addition of olanzapine of 15%. So that's quite an amazing reduction in no nausea, and or increase in no nausea. And the same for complete response overall, also a clear benefit. So the drawback here is the sedative effect of olanzapine. So maybe we should just go for 5 milligrams, and there are emerging evidence for that too. So what about chronic nausea? So now we have addressed nausea in the setting for patients receiving chemotherapy, but we have a huge population of patients with advanced disease suffering from chronic nausea. And this is really a debilitating symptom causing a lot of psychological stress for the patients in the last time. So this is a very, again, welcome trial, putting nausea as a primary endpoint. So this was a double-blind placebo and very special and nice clinical design. I'll not go into details, but this was a placebo run-in trial. So they all start with placebo, and if they experience excess nausea, then they were randomized to receive either NIPA, so nitaparsan and pulnazotran in the one arm and placebo in the other arm. And there was a significant within group improvement in nausea between days 5 and 15, but this was seen actually both for the NIPA arm and the placebo group. So we need larger scale clinical trials in this special population in need. So just a quick overview of the MASC ESMO antiemetic guidelines. Really, if you don't know this set of guidelines, you should certainly go and take a look at them. They are very useful in the daily clinic. We're about to update them, but as you can see, just drawing your attention to olanzapine for the high metagenic and AC chemotherapy. So it is optional to supply with olanzapine, and this would certainly be a good idea for patients experiencing nausea, because patients because olanzapine exhibits some very so it's a multi blockade of more than just dopamine, but a lot of other receptors. So yeah, so it's very efficacious for nausea. So this was for the acute and the delayed phase. And then just very shortly addressing also anti-medic guidelines in advanced cancer. So there's a newly published MASK guideline by the Palliative Care Study Group, and they make statements about the first line. You should go and have a look at the paper too. So metoclopramide and haloperidol is the first line treatment, anti-medic treatment for patients suffering from nausea and vomiting in advanced disease. So just rounding off with a conclusion, nausea is a complex and subjective sensation. It occurs with different underlying causes, and we actually need to treat the cause first, and then we can be left off with some nausea that we then need to take some symptom control over. And we can see that throughout the cancer trajectory. And nausea has a significant impact on quality of life. Modern anti-medic prophylaxis has markedly improved the control of nausea due to antineoplastic treatment. Nausea control in the palliative and end-of-life setting is challenging. It's difficult to do clinical trials in this setting, but it's highly needed. We have a lot of nice pharmacologic interventions, and those are important, but they are not always sufficient. So we have to take the whole patient into consideration and see what external factors can also be of help for relieving the symptoms. And then finally, nausea should be put as a primary endpoint in anti-medic clinical trials in order, of course, really to see what is the benefit of the anti-medics. And very lastly, individualized multimodal anti-nausea interventions will serve the future patients. So there's a lot to go for and in research. So with this, I'd like to say thank you, and please use the Q&A function. And then it's a pleasure for me to give over the screen to Matti, Aapro, and you were so very nicely introduced, but it can't be done enough. So I'm very glad to hand over to #1 special supportive care guy in Europe. Thank you, Matti.
Thank you very much, Christina, for your nice words, and Florian for introduction. I believe that all our efforts, those that are going on now and those of the past, have allowed us to reach a period in which things have clearly improved for our patients. But still, there's a lot to be done in some sub areas. And in the chat, there were some very interesting comments that we'll have to come back to, provided we have enough time. So this is the agenda that you saw. I'm going to speak about sparing steroids. And this is an area in which we certainly have made a huge progress compared to a few years ago when we were putting corticosteroids for days 1, 2, 3, 4, even 5. Now we tend to use them in many settings only on day 1, and sometimes maybe still in the guidelines on further days. And I'll try to convince you that the guidelines should be changed. And as you heard from Christina, actually the MASK ESMO Guideline Committee is going to look at the guidelines and adapt them to the data that is available. They'll share some of this with you. A lot of my slides, if not all of them, have been produced by my very good friend Luigi Celio, with whom I have had the opportunity to work for quite a while in this topic of sparing steroids. And I thank Luigi for sending me his slide set. When I was asked to talk about this, I said, I'm not going to reinvent the wheel, because I know that Luigi had given a very nice talk just a couple of months ago on this topic. And I said, why should I reinvent his slides? So thank you, Luigi. This is where I work, is the Genolier Healthcare Campus. We used to be the building in the middle there. Now we are all of these buildings. It's wonderful to see that that center is progressing, but that has nothing to do with me. Here's my so-called declaration of interest, DOI, as ESMO calls this nowadays. I think, as I always say, have enough of them to have none. Corticosteroids have been around since the 1980s, and we still wonder, why do they work? Why do they increase the antiemetic control? Why do they increase especially the control of nausea in our patients? If anyone has a good idea, more than the ones that have been on all the publications until now, it would be wonderful. We all know that using a little bit of corticosteroids boosts your general well-being in all settings. But what is the real reason why they work in the antiemetic setting for chemotherapy-induced nausea and vomiting? No one really knows. We know that there are various choices of doses of corticosteroids, depending on the antiemetic that you are using besides the corticosteroid. This is based on some historical data and probably should be challenged with the data that we have available today with combinations of NCAM receptor antagonist and 5-HT3 receptor antagonist, plus or minus olanzapine, but this was the tradition. And as you can see, they were used at some hefty doses from time to time. 8 milligrams BID for 3 to 4 days in high-risk patients. I believe that no one uses those doses anymore. Janet Vardy, a long time ago, 2005, and that's published in 2006, 2005 at the ASCO meeting, published 2006, showed to us that what we believed was such a nice and easy treatment, i.e. corticosteroids to decrease the impact of nausea and vomiting in chemotherapy-treated patients, was actually a problem for patients. It was a small but eye-opening study, 60 patients, almost half of them complained of insomnia. And still today, you know that some of your patients, even a single day of corticosteroids, will complain of insomnia. And sorry for the background noise, which is always happening when it shouldn't happen. Then we have other issues like agitation. And this is a major issue for some of our patients that have a problem with the mindset, and this can happen often. And then if we use them for more than 1 day, some of patients are going to have weight gain or also acne. So this is not a benign treatment. And you know also about the decompensation of diabetes because of corticosteroids, even a single day, and also issues in long-term use of corticosteroids, even at small doses intermittently, as we use it for nausea and vomiting. There has been applications, for example, on a negative effect on bone metabolism. So what we do know is that even though they have been in the guidelines to be used on the delayed phase, if you look at what clinicians actually do, and here's some data from a study that I was chairing a few years ago called PEER, and another one shared by Gilmore in the US called INSPIRE. In the delayed phase, where patients were supposed to receive corticosteroids, actually only half of them, or even less in the United States, received corticosteroids, showing that for many reasons, clinicians were already wondering whether they should really use them. It was not only the fact that we saw from these studies that unfortunately guidelines in general were not followed. What we then did was to run a study, a proof of concept study, using palonosetron as the 5-HT3 receptor antagonist and dexamethasone only on day 1, plus placebo, versus palonosetron, dexamethasone from days 1 to 3. And as you can see here, there is simply no difference in terms of control in the first 24 hours or 24 to 120 hours in the delayed phase. I recognize that we didn't look beyond this, and I commend the studies that have just been shown to us, showing where we stand beyond 120 hours. Other proof of concept studies were run by Luigi Celio and Dr. Komatsu from Japan. And you can see once again that overall, whether you use the long-term or short-term corticosteroids in these moderate hematogenic chemotherapy-treated patients, the previous ones were AC-treated patients, and these also had the majority of AC-treated patients, which nowadays is considered highly hematogenic. Nevertheless, for these patients, there was no difference whether they used 1 day or 3 days of corticosteroids. So the guidelines that were shown to you already by Christina consider that indeed for moderately metagenic chemotherapy, there would be no need to use corticosteroids based on the data from this study. So this is an acquired thing, even though still today we see colleagues giving moderately metagenic chemotherapy that will give corticosteroids for more than 1 day. And the same is true here for highly metagenic. It is dexamethasone days 2 to 4, as I told you earlier. So the big question here is, what is the situation today? Can we change the guidelines? What are the data? So we have here for the AC HEC highly hematogenic, as we tend to say that everything we do for AC and platinum and AC should be the same. Again, here the data for AC, which is nowadays considered HEC, to show that, well, a single day is not really different. And the advantage there is that we have to use a NK1 receptor antagonist, in this study, netipitant plus palanositron compared to palanositron itself. A wonderful study, even on the slide, and I left this from Luigi Celio, called an underpowered study for cisplatin. Dr. Ito showed that 1 day of corticosteroids with neprepitant palanositron combination was not that different. There was a slight advantage for 3 days, but the numbers of patients in the cisplatin group compared to the numbers of patients in the AC subgroup was such that you couldn't draw any real conclusion. So was this a difference? Not a difference. At least the non-inferiority margin was not met. So overall, and this is a meta-analysis that we published under the leadership of another of our distinguished Japanese colleagues. They have done fantastic work in this setting in the past few years, also looking at olanzapine and the olanzapine dose that we alluded to, that the 10 milligram dose is most certainly not the dose to be recommended. 5 milligrams and even less than that could be recommended, especially you want your patients to be independent, not with the risk of sedation and of an accident if they're driving a car. None of my patients on olanzapine is allowed to drive a car. So Okada showed to us in this meta-analysis in MEC and AAC treated patients that indeed we could go for a single day of corticosteroids. As you can see here, these studies were all run with the 5-HT receptor antagonist palanositron. So if you look at the data for the delayed phase, and this is meta-analysis published in BMC Cancer by Luigi Celio, once again, the same message, we do not need for these patients to use a corticosteroid. So to finish with the MEC setting, here's the data from Van der Forst in Oncologist just a year ago, showing once again that we can do without the corticosteroid. We also know that corticosteroids, we don't want to use them in the setting of immunotherapy. And we also have recommendations from MASC-ESMO because of the COVID pandemic, which is unfortunately still prevalent in many countries, that if we only could, we might want to reduce the amount of corticosteroids we use. So a nice review about this question for your interest is the one from Janovitz, published also in the Oncologist just a few months ago. And I would certainly recommend for you to bring it to the attention of all your house staff. Why should we reconsider the use of dexamethasone? And finally, the data from Luigi Celio in cisplatin more than or equal to 70 milligram meter square setting. 3 different arms on the study. The major question that we are asking here ourselves is comparing a NEPA plus DEX on day 1 only to NEPA DEX days 3, days 4, because the investigators couldn't agree should they use the DEX for days 3 or day 4. So he said, oh, let's have 2 arms so everyone can participate. And if you believe that there's a difference between 3 days of DEX to 4 days of DEX, look at the data, you see that there's no difference. And the main message is that there is really no difference in these cisplatin-treated patients, in the control, in the delayed phase for these patients. So we shall see if these data, the other data that I shared with you, will be enough for the committee to decide. And we are helped here by another study, which is done by Dr. Hashimoto. And here he used also the excellent drug olanzapine. And the question here was about olanzapine, which also provides you with some information about a lesser use of corticosteroids. And Shimomura in 2021, and I saw that we have quite a few Japanese attendees. They might want to make a comment here. Looked at 1-day DEX versus 4-day DEX, along with olanzapine and palonosetron, and once again showed that there is statistically no significant difference between 1 day to 4 days of DEX. The difference that is observed is not what was preset by the study investigators. So with this, I would like to conclude by inviting you to our Toronto meeting in June of this year. And of course, Dr. Scotté to the 12th Tau CTM meeting, which is dedicated to supportive care in Paris, France. It will be all online. You'll be able to participate. Just pay attention because of some changes in the ESMO scheduling of the ESMO Asia meeting. It was decided that it would be happening now on December 15, 16, not on December 1 and 2, so that all of our colleagues from Asia could also participate in Tau CTM. Please look at the website. It's going to be a very exciting program with very interesting talks. So to conclude, single-day DEX use is in the guidelines for AC regimens a day, and for MEC, single-day use of DEX should, in my opinion, be also for cisplatin-treated patients. Guidelines are under review, and most of supporting data was obtained with palonosetron as the 5-HT receptor antagonist. Thank you very much for your attention.
Thank you very much, Matti, as well as Laurent and Christina, for the excellent talks that you just delivered. We have so many questions. I'm afraid we'll have to spend 5 minutes after the previous time to try to answer to the whole questions, but be sure that we will try to answer in another time after the webinar. So first, Laurent, the first question from Vinod Sharma. In the console study, in the 120 to 168 hours, 15% had failed. Do we know who were these patients? Which risk factors, maybe?
I saw the question. You mean, do these patients between with long delayed vomiting are they the same than those that are vomiting before? It's unclear in the study.
Okay.
We don't have clear answer. I think that patients who have protracted CINV are already beginning to vomit or to have nausea before. It doesn't begin 5 days after chemo, but it should be studied more accurately.
Okay, thank you. And to answer to the second question, is MASC planning to recommend the inclusion of an assessment of the long delayed nausea and vomiting for CINV assessment? The guidelines are ongoing, so maybe it's one of the questions we will ask to ourselves. We'll see that. Thank you. A question to Christina. A huge question from Daniela Haselmeyer. Thank you very much for the great talk. Vomiting occurs much less frequently compared with nausea. Nausea is also much more distressing for patients. However, the guidelines have a focus on antiemetics, and in most of clinical trials, the focus is on HEC and MEC, and more or less on minimal low hematogenic ones. So the question is, how can we deal with patients on gemcitabine, for example, low hematogenic risk, who do not receive standard prophylaxis, but are very often very burdened by nausea and not vomiting?
Yes, so gemcitabine is low hematogenic chemotherapeuticum. So it's, according to the guidelines, we know that it's optional to use either a 5-HT3 receptor antagonist or dexamethasone or dopamine receptor antagonist. So if either of those fails, then we should go to the next level, to a moderate hematogenic level, and then add on another antiemetic for the next cycle. For these patients, it's true that we don't have much evidence. So most of the evidence is from, as clearly stated, from the MEC and the HEC situations. So we have to try different options to see what works best for that special patient. So normally I think that for when I used to use gemcitabine, it's been some years now, but I think that I had a very good experience with using corticosteroid actually for those patients. But it's so you must try and see what works best for that patient. That's my opinion. Do you have other opinions?
Matti, Laurent?
No, I think that when we don't have study data to back up, we can have good opinions, and I think your opinion is a very well educated one. So I'm not objecting.
Okay, you're too subjective. Which scale is the best for nausea assessment? Christina.
Which tool?
Yeah, which?
So I think it depends on what is the setting. So is it for a clinical trial or is it for the daily clinic? So my answer would be according to that. So in the daily clinic, I think that we can use the CTCAE for grading from so the clinician grading, but it's very important to have, especially for these patient reported. So the symptoms that are, so that we are very we don't really have a way to measure it. We can't see how is the skin, so we can't really measure nausea. So the patient reported outcome is very important. So using the Pro-CTCAE, it would be a very nice attempt in the daily clinic. So for clinical trials, we use both the visual analog scale and we can use a numeric scale, and there have been some nice studies trying to comparing these two scales in order if it's just as valid to use a 4-ligand scale as opposed to the visual analog scale, so it's accepted to use both of them. There are some minor data pointing to that the visual analog scale might be the most valid for this, but both are accepted.
Yes, Matti.
Thank you. This was a very important question, and I know that you are answering according to what is being done, but I have always said the same thing. My problem with my patients is that when I talk to them about nausea, I think of something. Then when I ask them what do they understand from what I talk about nausea, they will be saying what you said at the beginning of your talk. They will be looking at decrease of appetite. They'll be looking at the fact that they feel unwell. And in some languages, and I have a slide about that, is saying feeling unwell and having nausea is exactly the same thing. So it is extremely difficult. And that's why I continue to say that there are different components to nausea, and the nausea-related chemotherapy elicits other issues that then can be related to what is called nausea, but probably is not going through the same pathway. So we have to think in different way. And I believe that that's one of the reasons why olanzapine is so active in the setting of nausea, and that's probably something to do with the perception, and that is also something where the corticosteroids play a role. But I think we are not going to lose the time of our distinguished guests and attendees here on this debate. Let's move to another question.
Okay, so just to move, and for you, Matti, from Vinod, the question is about the endpoints to use: complete response rate, or nausea endpoint, or quality of life.
These are complementary answers. The complete response rate is an easy one, measurable and very well defined. If you look any type of quality of life questionnaire, it can always have issues depending on the environment in which the patient is. And some of the questions are not relevant. For example, for some of my elderly patients that will look at the question will say that is not relevant for me. So I think we have to use both scales, and the best is really to have a complex way when we really want to analyze. But if we want to go grossly, what was stated before by Christina is the right way to go.
Okay, and how do you address drug-drug interactions with the addition of olanzapine, specifically in QTC prolonging agents?
Well, this is a question that makes me think that our distinguished colleague must be a friend of regulators. Regulators have a major issue with QTC prolongation, so they see it absolutely everywhere. In clinical practice, even though we have to recognize that some, but not all, of the 5-HT receptor antagonists, because palonosetron does not prolong QTC, this prolongation of QTC and potential interaction is, to my eyes, probably non-existent. But if regulators in any country put this forward, then you have to follow the rules of that particular country and run an EKG.
Thank you very much, Matti. And the question for the panel: what do you use as prophylaxis for multi-day chemotherapy? That will be a question asked in the guidelines, but I would like to hear you from that. Maybe Laurent first.
Well, first, it depends on the number of days, but I use the combo netupit and palonosetron up to 5 days, and sometimes combined with olanzapine.
Christina?
Well, we use the same, and then we have an add-on of palonosetron during, so it's if it's for 5-6 days as cisplatin, then we use palonosetron on days 3 and 5 also.
And Matti?
Well, as you heard already, we have variations. We have rarely to treat patients with chemotherapies that have clearly defined agents that elicit moderately or highly mutagenic reactions on days 2, 3, 4, and 5. So our personal experience is relatively modest in generally, but if you look at the literature, there are some data from colleagues that have run some studies on using these agents on days 1, 3 because of the prolonged action, and it's especially true for the netupit and palonosetron combination. So that you absolutely will not use them on days 1, 2, and 3, but days 1, 3, and if needed, maybe on day 5, because the prolonged presence of netipitant, you could skip that and just give palo. If you're using a compound like fosaprepitant, you can also use it in a relatively similar way according to some of the literature. But this is clearly an area where we need good studies to know what we are saying is really backed by the evidence.
Thank you. What medication do you use for patients under radiotherapy at home if you already used the cetron in your prophylaxis?
This is a question for Christina.
Yes.
So if a patient already had, for instance, ondansetron during chemotherapy, so it's for combined chemoradiotherapy, that was the question?
The question is only under radiotherapy.
Okay, so if it's if it's a high metagenic chemotherapeutic or a radiotherapeutic regimen, then we would use in our institution we would use ondansetron daily, and maybe it's not needed, and then we'll go to an as needed situation. But ondansetron is the one that we would use most. And for patients with severe constipation problematics, then we will switch to a dopamine receptor antagonist if they don't have a diarrhea. So this would be our primary options.
Thank you very much. So it's time to close this webinar. Thanks very much to all of you, all of the panel, for your very great talks. We have a lot of very interesting advice on the webinar and so many questions. I think that we are near 30 or 40 questions, so we don't have time enough to discuss all of them, but we'll try to answer after the webinar. Thanks again to Helsinn for his grant, and thanks to the MASC for endorsing this webinar. Please become member of MASC, and please attend MASC meeting, the annual meeting at Toronto in 1 month, June 23 to 25. Thank you very much, and enjoy the end of the day.
Bye-bye.
Thank you.
Goodbye.
Yeah.
Thanks.
Bye-bye.